Welcome. I'm Dr. John Ianian, a professor of internal medicine, health management and policy, and public policy at the University of Michigan, and director of the Institute for Healthcare Policy and Innovation here. It's my pleasure to welcome you as the moderator of today's webinar on wicked problems in vaccine equity, exploring challenges and opportunities for impact. We'll be running the webinar for about 90 minutes, and we have a very exciting panel of speakers joining us today who bring diverse perspectives on the topic of vaccine equity. In formulating the remarks, we've asked each of our speakers to address three central questions related to vaccine equity. How does your perception of vaccine equity shape the work that you do in this domain? What is a wicked problem in vaccine equity that you and colleagues are wrestling with? And finally, how could a multidisciplinary collaborative approach with global partners advance vaccine equity generally and with the specific wicked problem you identified? The members of our audience viewing and listening to today's webinar will have an opportunity to pose questions and responses to our five panelists through the Q&A box in Zoom, which our panelists will discuss after they have completed all of their opening presentations. Our first speaker is Dr. Joseph Mathew. Dr. Mathew is Professor of Pediatric Pulmonology at the Postgraduate Institute of Medical Education and Research in Chandigarh, India. He has expertise in pediatric respiratory disease, vaccinations, and evidence-based healthcare decision-making. Dr. Mathew has conducted research on multiple vaccines, including hepatitis B, measles, influenza, varicella, rotavirus, and typhoid, among others. Please join me in welcoming Dr. Mathew from India, where it is Friday evening as we speak. Welcome, Dr. Mathew.
Thank you very much for this nice welcome. I'm also grateful to Professor Boulton and Professor Kohlers for inviting me to be here. And it's great to be able to share a few thoughts on this important topic with an international audience. Before I just begin my presentation, can I confirm that the opening slide is visible?
Yes, it is.
Thank you.
Thank you.
Thank you. Thank you. So I'll just launch off into the topic straight away. So the theme I've given to my presentation is actually vaccination inequity and inequity in vaccination, and I'll explain these two words as we go along. Now, to give a little bit of background, India was an early adopter of the World Health Organization's expanded program of immunization in the late 70s, and we used 6 antigens to target against 6 vaccine preventable diseases. All of those diseases were widely prevalent before the EPI program, and they continue to be prevalent even after the EPI was launched. So the question that came up is, was it failure of the vaccine? Reasonable assumption, considering that we were a tropical country, cold chain problems, and a lot of difficulties. Or was it a failure to vaccinate? Now, data through the late 70s, 80s, and 90s seem to show that we had good vaccination coverages. These are the official Government of India figures showing vaccination coverage in high 80s or 90s. But this myth was punctured by the independently conducted National Family Health Survey NFHS series of data, which interviewed individual families to find out the vaccination coverage. And this survey showed a decline of 20 to 40% as compared to the official Government of India figures, which are shown in these green bars. And this is late 90s. Around the same time, again, the official coverage figures from the Central Bureau of Health Intelligence of the government showed very rosy picture of vaccination coverage, but the independent survey conducted by WHO UNICEF was much, much lower, almost a 30 to 40 percentage point decrease in terms of the vaccination coverage. So basically what it meant is that we could not rely on the official data and we needed independent surveys. And that then became the basis for the NFHS series, or the National Family Health Survey series, becoming the prime data source for vaccination coverage in India. 5 such surveys have been conducted at a few yearly intervals. The latest has just been finished in 2019-20. We don't even have the full data. What it shows is that the rosy picture is not so rosy. Our vaccination coverage estimates over 2 decades have been ranging from 30% to about 60% for full vaccination, and the proportion of children who are totally unvaccinated range from about 20-25% to as much as 8 to 10% in the last survey. So there has been a problem with vaccinating children. Now, the difficulty with looking at coverage estimates is that it reflects program efficiency in the sense that how well the program is doing. But we're interested also to see what's happening to the children within the program and how is the vaccination coverage distributed across different age groups. And that is what brings us to the concept of equity. Now, by and large, the usual understanding of the term is creating equal opportunities for vaccination. But my own perception has been that that is not enough. We need to identify the groups of children which remain at high risk of being un or under vaccinated, and then find a way to bridge those gaps and redress those imbalances. Now, when I started looking at equity, there was no formal definition, but in recent years, there has come about a formal definition for this term. I've just put it there on the slide. Don't bother to read it. It pretty much reiterates what I just said over here, that looking at the gaps and who doesn't get vaccinated and trying to plug that. I think much better than the definitions is this beautiful cartoon that I picked up out of Google, which actually looks at the difference between equality. Many of us think that this is what equity means, providing an equal opportunity to different sections of the population so that they can all stand kind of on the same height or box. But equity actually looks beyond this. It looks not just at the process of providing opportunities, but it looks at the process in terms of the outcome. Now, there's no point in having this kind of equality or equal opportunities if it didn't translate into an equal outcome, in the sense that it didn't give an opportunity for all of these children to be able to see this baseball match. That is what equity actually represents. And I think based on that understanding, about 10 years back, I got interested in this topic and managed to publish a systematic review on equity in the Indian context. And this is what we looked at that time. Now, those who are familiar with India would know that boys are the preferred gender over here. So just looking at the difference in vaccination coverage between boys and girls, these pink and blue bars represent the vaccination coverage between boys and girls for the NFHS 3 series. And you can see that full vaccination has been about 5 percentage points different. And for each individual vaccine, which is what is represented by these abbreviations below, there has been a 2 to 4 percentage point difference between boys and girls. In the next series, which is represented by the orange and the greenish colored bars, you see that the bars are almost equal in height, but there is a slight difference of about 0.5 to 1 percentage point. So we've done better, but we're still not at the level where boys and girls are equally vaccinated. And when I tell you that because we have an annual birth cohort of 27 million, so 1 percentage point difference is 270,000 children, then you will understand the impact of these small 0.5 percentage point differences between boys and girls. Now, looking at inequity within the family, that is looking at children by birth order, it throws up a very interesting picture. So the firstborn child seems to have a coverage of about 50-55%, and then each subsequent child seems to be having less opportunities of vaccination. And you see this beautiful step ladder declining pattern with increasing birth order, both in NFHS 3. NFHS 4 bars are slightly better, but they show the same pattern. And children who are totally unvaccinated seem to be doing pretty much the same way in both of those series. So higher the birth order, less likely that the child is vaccinated. Looking at the family income or economic status, these bars actually represent 5 different wealth brackets in Indian population. You can see a beautiful step ladder pattern wherein the most wealthy population seem to have the best vaccination coverage, and the least economically empowered had the lowest vaccination coverage. In the NFHS 4 more recent surveys, you can still see the step ladder pattern, although the gaps from 50% range have declined to about 20%. Looking at maternal education and looking at the 6 brackets by which maternal education is counted in India, the same pattern there again. Mothers who's having the lowest educational status, their children are least likely to be vaccinated, and the better educated mothers show the best vaccination, and there is a step ladder pattern. The disparities continued in the more recent surveys, although the gaps have narrowed down. Now, therefore, this kind of an inequity by individual child characteristics and societal characteristics, we decided to look further and see whether having combinations of these risk factors had a cumulative impact or they just remain like this. And I was fortunate to have Dr. Boulton's team, Dr. Deepti Betampadi, his PhD student who had just finished, and Brad Carlson from the School of Global Health. They collaborated with me on looking at multiple risk factor impact on this same topic which I just presented to you in the previous slides. And I'm summarizing the results in a single slide over here. It's slightly complex. So what we have at the bottom over here is those 4 risk factors that I talked about: girl gender, birth orders more than one, low wealth, and illiterate mother. And if you did permutations and combinations of these 4 factors, we get a strata which goes into 16 levels, depending on how many or which of these risk factors are present. So we looked at the odds ratios of being fully vaccinated based on the number of risk factors that an individual child had by looking at the raw data from these surveys. And we found very interesting patterns. If you looked at 4 risk factors together as the base or reference stratum, children who had 3 risk factors did slightly better. Those who had 2 risk factors did even better. Children who had only 1 risk factor did even better. And at the end of this chart, in the corner, is the children who had none of these 4 risk factors, and they had an odds ratio ranging from 4 to 10 compared to the children who had all the 4 risk factors. So this means that looking at inequities by only one individual risk factor at a time is not sufficient. We need to look at them cumulatively, and there can be an almost 10 times difference in vaccination coverage in terms of the odds ratios if you had multiple risk factors compared to 1 or 2 alone. And amongst these individual risk factors, the one which seemed to make the maximum impact was literacy among the mothers, because children whose mothers had some levels of literacy seemed to show slightly better vaccination coverage, even if we looked at them within the same risk factor. So I think in summary, what we learned is that there is a lot of inequity which is happening at the level of the family, the society, the community, and also the vaccination program in India. Now, with those thoughts in mind, I'm going to switch gears a little bit and come to the topic that I mentioned before, wherein I mentioned inequity and also inequity. What is the difference in a word? Now, I already talked about the fact that inequities or equity should be looked at beyond providing equal opportunities. There is a sense of fairness or justice which is involved in the term inequity, and the dictionary meanings across all those dictionaries that we find in Google actually talk about the sense of fairness or justice. When this lack of fairness or justice becomes bordering on the immoral or grossly unfair, that's when inequity becomes inequity. So the words are very similar, it's only a difference of one letter. But I chose this particularly because there is a lot of inequity which is going on, which contributes to the inequity. And I'll talk about this in the moment to come. And I asked Christabel, why you have chosen this word wicked problems, and she explained to me in the American context. But I think there is a bit of wickedness actually which perpetrates this inequity, and I'll come to that in a moment. Now, the first thing I wanted to talk about is, how inequities become almost iniquitous. Professor Boulton again gave me an opportunity to publish a paper in the supplement. And if my time runs out and I'm not able to cover all that I have in my slides, I'd urge everyone to look at this paper. It's in the special supplement on vaccination equity. It covers a lot of the stuff which I'm going to share with you in a moment from now. Now, first and foremost, inequity and inequity in the focus of vaccination. I'm going to take you back 30 years. This is data from 1990. This chart pretty much shows the vaccine preventable diseases across the different WHO regions of the world. So these abbreviations represent different regions, from the Southeast Asian region on the left to the WHO Americas region on the right. And each of these bars represents the burden of disease for each particular disease, like diphtheria, pertussis, etc. So if you were a policymaker in any part of the world, flush with the success of eradicating smallpox in the late 70s and enthused with eradicating another disease in the 90s, you would obviously choose the ones which had the biggest burden, and that is measles, represented by these orange bars over there. In every part of the world, measles has been outnumbering anything else. But surprisingly, the focus went to poliomyelitis, and much of the developing world was not even grappling with big problems with polio. You can see that these green bars are very, very minuscule compared to these orange bars over there. India was dragged in somewhat reluctantly to sign up for this eradication program, and we signed it up in 1988. Please don't try to read these numbers, but believe me when I say polio was not one of the big problems. It was measles, to some extent pertussis, but because measles kills and creates long-term complications, measles would be the one disease that should have been targeted. Why then did the focus shift to poliomyelitis? And paradoxically, the answer is not found in the high burden of disease, but it's in the low burden of disease in much of the developed world. And I'm sharing data from the United States from 80s right to the early 2000s. And what this pretty much shows is that in the year that the world signed up to eradicate polio, polio had become a small problem in the United States. It was, handful of cases, such that the only way to protect children permanently and have the dream of eradicating polio and getting rid of polio vaccination would be if the world signed up to global eradication. Because of the importation of cases from Latin America, to some extent from Asia. And you can see that once this eradication initiative was signed up for, thereafter the US has remained polio free, and much of Europe, especially Northern Europe and most developed countries, have had this benefit. Whereas the developing world has continued to grapple for decades, and we still don't have the stage at which we can call ourselves fully globally eradicated, in the sense that the vaccine is not needed. So you see how a little bit of shift in focus can change the picture entirely. Now, the inequities and iniquities which come because of public health decision making for vaccination in the developed world, what usually decides which vaccines are important is a disease epidemiology, burden of disease. So there is a need based on the burden of disease. The solution is found in terms of development of a vaccine or a deployment of the vaccine if it exists. And healthcare stakeholders from industry to health vaccinators and everyone scrambles to find a solution to meet that need, which is determined by epidemiology. Now, in the developing world, what happens is we don't have data on epidemiology, so we don't know what the burden is. We make estimates or guesstimates. The solution, which is an imported vaccine, is licensed for sale in the open market. So the solution is there, and people scramble to find a need to fit that solution. So when that is not generally there, an artificial need is created and supported by vaccine industry, international agencies, to some extent the domestic agencies in the market, and healthcare stakeholders are moving from a solution to need rather than from a need to a solution. And there are countless examples of this. Because of paucity of time, I won't be able to describe the specifics of each particular vaccine. But I did manage to publish this as a small note in BMJ in the late 2008 edition of this journal. Now, policy decisions in developing countries, I already mentioned to you, are to some extent skewed. And then in India, we had this problem that the indigenous public sector vaccine manufacturing units were shut down in the 90s, which means we had to depend on private manufacturers within the country and multinationals from outside the country, and the prices were set by the manufacturers. The Indian government did not have the capacity to leverage its purchasing power, given that we had a birth count of more than 26 million, 120 million assured doses for most of these vaccines each year. But we still didn't succumb to the demand-driven mode, and we were driven by the market forces. And that resulted in haphazard vaccination across the country, with the rich being able to afford some and the poor people who needed it not being able to afford any vaccine. Now let's look at the role of the global agencies in perpetrating this inequity and the inequity. I'm showing you now a screenshot from the WHO's position paper on pneumococcal conjugate vaccine published in 2007. At that time, we had the 7-valent vaccine. I'm just going to read out the sentence over here, which says the WHO considered it a priority that this vaccine should be included in national immunization programs in countries where the mortality among children aged less than 5 is more than 50 per 1,000 live births, or an absolute number of more than 50,000 children annually. Now, this makes absolute sense on the face of it, but people like me were kind of worried about this. Where did the WHO come up with these cutoffs of 50 per 1,000 and 50,000? Why? Why not 30 or why not 100 and things like that? And more important, why did they use this word or when it would have been made much more sense to use the word and, because then both these criteria could have been used to cover it. And it took me a year to look at the mortality data from each of WHO's member states, which is about 200 at that time. And then I found something very interesting. If you look at having both the criteria, it included 38 countries, including India, and that accounted for about 298 million children worldwide. But the problem is that most of these 298 million children resided in Africa, which didn't have the capacity to purchase that expensive vaccine at that time. So that would have not translated to much benefit, having a recommendation of using both criteria together with the word and. Children who fulfilled only this criteria of having more than 50 per 1,000 live births were only 18 million in the world, not much of a vaccine market. And that brings us to the advantage that we had by the WHO putting the word or, because just using the word or gave 161 million additional children which could be vaccinated by that word or in the WHO recommendation. And these 161 million came mostly from China, Brazil, Mexico, and Indonesia, emerging markets at that time with the capacity to buy and use the vaccine. And that's exactly what happened. The WHO recommendation was taken very seriously. The vaccine was used in all of these countries, and a nice market was found despite the fact that epidemiological data was not available in these countries at that time. India struggled, of course, for another 10 years and got it in much later, and we still done it in a very patchy fashion. Now, this little, deft wordplay was exposed in a publication which came in 2009, and I'd urge you all to read that also if you have the time for it. My time is running out, so I'm going to go quickly to the role of the Indian Academy of Pediatrics, which is the sister agency of the American Academy of Pediatrics. Just like you have an ACVIP in US, we have one in India, which periodically releases statements, papers, recommendations favoring new vaccines. But there the similarity ends, because our Indian academies, most of the guidelines have certain common features. One, the disease that the vaccine is targeting usually becomes a priority once the vaccine comes into the market. Until that time, nobody seems to know about the disease. But once the vaccine is in the market, the academicians scramble to find ways to make it a disease which is a priority. The statements are always in favor of vaccine. The lack of burden or lack of local data has never been a deterrent. The guidelines are couched in terms that they're meant for practicing pediatricians, which means those who can sell the vaccine to the families and charge for it. But the IAP also dabbles in recommending to the government of how the vaccines can be introduced. In other words, unlike the AAP, where the need drives the solution, the Indian Academy of Pediatrics relies on the solution driving towards the need. Now, industry, of course, has been involved in this iniquitous distribution of vaccination, because they market vaccines whether or not it is required. The government allows them to provide by providing them a license. The prices are set up by these MNCs themselves. They use two channels to target the vaccination marketing. One is the academic channel by sponsoring educational activities. You can't walk into a pediatrics conference or meeting anywhere in the country today without having one or the other in hot vaccine discussion. And the amounts of sponsorships are phenomenal. They actually burden on the obscene and definitely on the inequities. The commercial channel includes marketing to and direct to the consumers through TV ads and paper ads, and also by providing vaccines at less than consumer retail prices to the pediatricians, who then have incentive to market this to the customers or the population themselves. Consumer empowerment has been rather poor in India. People have the total freedom to make vaccination choices. Vaccination is not compulsory in the sense that it does not attract punitive action, but expensive vaccines are often forced onto families by covert and overt means, wherein the overt means are direct advertisement, in which the ads in the TVs and the newspapers are targeted towards people who don't have the empowerment to understand what these actually mean. And then healthcare providers, because they get vaccines at cheaper than retail prices, they perpetrate this inequity by pushing vaccines onto families, even if they are not able to get. The fallout of all this is that families sometimes make guilt-driven choices and give 1 or 2 doses to their children. So the series remains incomplete and children continue to remain unprotected despite having partial vaccination. Now, in the document that I talked about in the publication that I just mentioned to you, there are 3 supplementary files which I would urge you to read, and they would expose the inequities in Indian vaccination scenario for hepatitis B vaccine from the early 90s, polio vaccine, which came from the late 2000s, and now the pneumococcal conjugate vaccine in the current decade. Please have a look if you have the time for it. I'm going to wind up with one single slide. What is the solution? What is the way forward? I think, again, I'm going to rely on a cartoon that I picked out of Google. This is the current situation wherein the system is skewed in favor of certain part of the population. Equality of providing equal opportunities is not going to solve the problem. This is the usual crude understanding of the word equity. This is just going to perpetuate the problem in which those who have will continue to have more. Equity in which opportunities are provided such that those who don't have can also get it is going to be one way to redress the imbalance. But I think we need to focus on the word inequity and not just inequity, and look for social justice wherein the system is altered in such a way that you don't really need to provide additional opportunities, but you need to skew the system such that everyone has equal opportunities to get the vaccines, and then make sure that these children, they become the main beneficiaries and not the other stakeholders in the whole development process of the vaccine. I've exceeded my time. I apologize for that. And thank you all for your patient hearing. And I'm going to stop screen sharing at this point. Thank you very much.
Thank you, Dr. Mathew, for your excellent presentation that was very rich in content. I want to remind our viewers, if you have any questions or responses to Dr. Mathew's presentation, please put them in the Q&A box at the lower right right-hand corner of your Zoom screen, and we will return to your questions after our other panelists have spoken. I'd now like to welcome our next speaker, Dr. Diane Harper. Dr. Harper is Professor of Family Medicine, Obstetrics and Gynecology, Biomedical Engineering, and Women and Gender Studies here at the University of Michigan. Dr. Harper.
Thank you, John. I'm going to try to do this correctly. There we go. So I really enjoyed Dr. Mathew's discussion and the concept of, is this a solution looking for a need, or is this a need looking for a solution, is really intriguing. My particular work has been on the human papillomavirus and the vaccine that has been developed to prevent human papillomavirus infections. As most of you know, human papillomavirus has been linked as the causal agent for cervical cancer and for a very high number of oropharyngeal cancers, as well as anal cancers, some vaginal cancers, and some penile cancers. So it does affect both men and women, but it predominantly affects women. And initially, as I was listening to Dr. Mathew, I was thinking, well, no, this is a need. We know that we need this to prevent cervical cancer. And then I thought, you know, maybe it's really not. Maybe the development of the HPV vaccine was a solution to a need seen by somebody in the United States, but it's actually now being trying to find a need in other world countries. I emphasize that because cervical cancer is the #1 killer of cancers of women in countries that are what we consider less developed or have a lower GDP. What you see on the screen in front of you right now is the population uptake of the human papillomavirus. I would also note that in contrast to the vaccines Dr. Mathew was talking about, the human papillomavirus vaccine is geared towards children as young as 9, but most places are doing it between 11 and 15 years of age as the age at which they give it, which is a kind of awkward age in the life of a child, especially with children who don't have regular health care. So what we can see is that while the vaccine's been available for 15 years, we have very disparate uptake of the vaccine throughout the world. Now, what I want to show you next, if I can move to the next slide, is this is where the distribution is. This was as of 2016. Can you guys actually see the very top of the slides, or is that cut off?
We see the income categories listed at the top.
That's great. That's what I want you to see. Okay, so I'm going to start at the very right-hand side of the screen. And what that is countries that are considered low-income countries. And what that means is the gross national income per head is $1,045 or less. So that is what the gross national income is for a low-income country. In low-income countries, 16% of cervical cancer cases worldwide are there. Now, in part, the reason is you see a population distribution curve. So you see on the very bottom, that axis is the number of women in millions, and the axis, the y-axis going up, is their age, their birth cohort. So that you see that lots of babies are born, but they die pretty quickly, and the entire population has pretty much weaned out by the time the women are 30 or 40 years of age. Cervical cancer takes about 15 years from infection to become cancer. So we would expect that the women are dying before we actually have the cancers developing. So that's an issue, but not an issue of vaccination. The second category is the middle income or the low middle income countries. The LMIC countries have more than $1,045, but less than $4,000 per person. This is where 40% of the cervical cancers are worldwide. And what you see here is there's a whole bunch of women that are born. There's a better survival rate. So you get more people to middle adolescence in their 20s. And then you have a pretty quick, steep decline in older age, so that you don't have people that are living to a very long period of time. And then we move to the next column, which is upper middle income women or upper middle income populations. And that gives us an income per person up to $12,000. And what you see here is that there's kind of a bumpy curve. The kids do well at birth, and then the population apparently had a time where they did really well at birth, and then it starts to have episodes of where it declines and there are death rates. But in general, the population lives longer, and more of the people live until they get to be in their 60s. And then on the far left-hand side, you see the high income. In the high income countries, they make more than $12,000 a year. And that's where 14% of the cervical cancers reside. And what you see is pretty much a rectangle of the people that are born pretty much live until they're 72, and then they start to die. So it's a very different life expectancy in this. Now, what I want to say is that where 70% of the cervical cancers are those middle two groups. And if you look at the color coding of it, the blue is the areas in which HPV vaccine has been made available to the population. And the pink is the population that accepted the vaccination. And so I think what is very clear to see is there is both inequity and inequity, as Dr. Mathew has called it, in that there is certainly not equal distribution around the world for HPV vaccine, nor is there distribution where the burden of cervical cancer is the greatest. The second part of that is that if you look in the far left under high income, you see of the population that's targeted, less than half has actually taken the vaccine up. This is something that is near and dear to my heart because the WHO has indeed decided that they have a cervical cancer elimination program. That program is called the 90-70-90 program, where 90% of people up to 15 years of age receive HPV vaccination, where 70% of women receive at least a once-in-a-lifetime cervical cancer screen. And of those who are identified with an abnormal screen, at least 90% of them have access to some kind of treatment. So the question that comes up with HPV vaccination is, if we could just vaccinate the world, we wouldn't need cervical cancer screening anymore. And I think that that's a fallacious argument. And I want to show this in a couple of ways. This is my last slide. The year on the bottom axis goes from 2015 out to 2080. And on the y-axis, it's the cumulative number of expected cervical cancer cases. And then each of the different curves shows us what's possible, what the future could bring based on modeling exercises. And the part that I want to call your attention to first is the light green. It's kind of squished in there, the one that has 65,609 on it. That is the expected number of cancer cases to be reduced if people had one dose of HPV vaccine. And that, I think, is incredibly important because at this time, the WHO has said that 2 doses is considered the standard dose for HPV vaccines, and that they should be given at 0 and 6 months. We have great data to show that you could give it at time 0 and then again 3 years later, and you would get same booster responses. So there's a significant amount of cost associated with increasing number of doses and increasing manpower to get the people the repeated doses. But there is a greater reduction in the cancers if you can get more doses in per person according to this model. But I think the thing that is even more stark in this is that all of the blue areas are the people who are going to get cervical cancer, irrespective of what happens. It shows that if they get vaccinated, 513,000 will still get cervical cancer from the other HPV types that's not covered in the vaccine. And of those that are 162,000 will then be due to the non-1618. I think I just said that backwards. The 513,000 are women who are not vaccinated, and the smaller number are people who still get cancer even though they've been fully vaccinated. And so I think what this shows us is that the ability to self-screen, the ability to have in the field screening, the work that's being done in twice in a lifetime cervical cancer screening with potential in-field diagnostics and in-field treatments could be a better way of looking at cervical cancer prevention. But I think the interesting part of this story for this particular conference is that it is a vaccine for both men and women, for both girls and boys, and that the relative contribution of vaccinating boys to prevention of cervical cancer is highest when the vaccination rate for girls is smallest. So in other words, in all of these countries that have low income or low middle income, where there's very low uptake of HPV vaccine among girls, we would be best served by targeting both boys and girls until we get that rate up to about 30%, at which point moving to an all-female vaccination strategy would work. But it brings in ideas of equity, of gender equity, of who should get the vaccine, who shouldn't get the vaccine. And many of the topics that Dr. Mathew commented on in his talk exist for this topic as well. So I am excited to answer any other questions people might have at the end. And I'm glad to be able to share that information with you.
Thank you, Dr. Harper. We'll now move to our third speaker, Dr. Mathew Boulton. Dr. Boulton is Professor of Epidemiology and Preventive Medicine and Senior Associate Dean for Global Public Health at the University of Michigan. Welcome, Dr. Boulton.
Thank you, John. It's a pleasure to be here today. I'm not going to be using slides, just going to share some brief thoughts about global vaccination equity. First, I want to start out by saying that my initial exposure to the concept of vaccination inequity was about 10 years ago when I read Dr. Mathew's paper that he alluded to in his presentation. In fact, I was so intrigued by the concept that I went halfway around the world and tracked him down in South Africa at the International Emerging Infectious Diseases Conference. And we've been research collaborators since then. I hope that doesn't make me sound like an international stalker, but I know that for my part, the collaboration has been tremendously beneficial in expanding my understanding of vaccination equity. My research focuses on quantifying the impact of the social determinants of health on childhood vaccination in low and middle income countries, especially China, India, Kenya, Ethiopia, and South Asia more generally. I'm especially interested in quantifying both disparities and inequalities in childhood vaccination. I've long thought that an important starting point for addressing vaccination equity is in the characterization of differences that we see across groups by socio-demographic and economic status, certainly, but also looking at the role of maternal education and maternal autonomy, urbanicity, religion, and the impact of institutional birth and having attended birth as important factors that are predictive for vaccination. All those factors and many others to varying degrees can have an impact on whether a child is in the right place at the right time to receive the right vaccine. And what we consistently find across countries is that there are vulnerable groups, whether because of their ethnicity or status as an immigrant, or because they fall out in a certain socioeconomic strata, whatever the factor or factors, it places them at higher risk of being under-vaccinated, so receiving some but not all of the recommended vaccines, or completely unvaccinated, that is, not receiving any vaccines at all. And it's not just that these vulnerable individuals or groups don't receive some of the vaccines, it's also that the vaccinations they do receive are much more likely to be untimely. That is, they're likely to be administered late, which places them at unnecessary and prolonged risk for acquisition of illness and a higher burden of vaccine-preventable disease-related morbidity and mortality. And therein is one of the major limitations of aggregate vaccination coverage numbers, which is how vaccinations are typically reported internationally, whether from UNICEF or WHO or the Global Burden of Diseases reporting. And what I mean by that is that you'll generally see a country reported as attaining complete vaccination with some or all of the recommended vaccines for a certain proportion of 12-month-olds or 36-month-olds or children under 5 years of age. So the report might reveal that 90% of infants at 12 months have received basic immunization series of hepatitis B, polio, DPT, which is diphtheria, tetanus, and pertussis, and the measles vaccine. Although that number provides important information both for the country and for cross-country comparisons, it masks the timeliness of vaccination such that some or most of those vaccinations are being administered late. And those vulnerable groups I mentioned earlier are much more likely to be subject to untimely vaccination, which generally, again, translates into a greater burden of vaccine preventable related disease. However, beyond that, and this is where we transition to what I consider a wicked problem in vaccination equity, is that aggregate number fails to capture the heterogeneity of vaccination receipt in a given country. Our research group is making more use of tools that allow for spatial temporal mapping of vaccination coverage at different levels, at the level of the neighborhood, village, district, or a scale that yields more information than just aggregate coverage numbers for the entire country or a large political division like a province. When you do that, what you find, including in the US and other wealthy nations and in low and middle income countries, is that vaccination coverage is not evenly distributed in the population, but rather it appears like a patchwork quilt with clusters of non-vaccination interspersed about, and that tends to become more apparent when you use a finer scale of resolution. And the non-vaccination clustering we see often occurs among persons of similar social determinants, whether that be their socioeconomic status, their religion, their caste, where they live, or their ethnicity. That is extremely important for several reasons. One, it permits a much more nuanced understanding of vaccination coverage and distribution and vaccination equity. And it also explains why in the face of high vaccination coverage, we can still see ongoing transmission and outbreaks of disease. That is, non-vaccination clustering potentiates disease transmission beyond what we would expect based on aggregate immunization coverage data. And we need to understand those non-vaccination clusters much better than we currently do. And there's no doubt that sociological and anthropological insights could greatly inform our understanding and place these in a social, cultural context that could assist with their identification. And intermixed with this clustering are considerations of vaccine hesitancy, which likely contribute in part or full to these clusters and point to a critical role of health behaviorist colleagues who have the expertise to formulate interventions that could positively impact vaccine decision-making, leading to an increase in vaccination coverage. And so finally, I'll just wrap up by saying that the World Health Assembly 2030 or developed a 2030 immunization agenda. And it's stated there, it envisions, and I quote, a world where everyone, everywhere, at every age fully benefits from vaccines to improve health and well-being. And I think that that nicely sums up the vision of global vaccination equity that I hope I can contribute to achieving. Thank you.
Thank you, Dr. Boulton. Our fourth speaker is Dr. Pascal Leway. Dr. Leroueil is Vice President for the healthcare sector at the William Davidson Institute here at the University of Michigan. Welcome, Dr. Leroueil.
Good afternoon. So quick overview of what about I'm going to talk today. First, I'll give you a little bit of background on the William Davidson Institute at the University of Michigan, since I imagine a number of you are not familiar with it. Then I'll touch on a wicked problem that my group has been tackling for the last couple of years. And then I'll close with some brief thoughts about what this group is trying to do right here. So William Davidson Institute is an independent nonprofit organization that's housed within the University of Michigan's Ross School of Business. So we apply basic business principles to solve challenges in healthcare, education, energy, and finance. And we've got two cross-sector groups within our organization. One is the communications group, and the second is the performance measurement and improvement group. So we do three types of works. One is consulting, so basic management consulting. The second is the more traditional academic research. And the third is training, and that's training of students both at the university as well as outside of the university. So as an organization, we've worked on a number of projects with faculty across the university, particularly in the business school, but also in the School of Medicine, the School of Nursing, the School of Public Health, and the School of Law. We tend to be opportunistic in terms of who we engage with. And by that, I mean, if we see a project that's interesting to us, but we're lacking that deep expertise that we need to complete it, we go searching through our own network, and sometimes we go on department websites because that's what we have available. On the next couple of slides, I'm going to talk briefly about a project we've been working on that's focused on tackling what we think is quite a big, wicked problem in the vaccine space. I'll say now that this was a project we had not engaged U of M faculty with, and it's one we probably should have, particularly in the beginning. And after hearing Professor Boulton's talk, I definitely think I should have engaged with someone here at the university. So the wicked problem that we were trying to address was, how do you prioritize investments in vaccine R&D and manufacturing if profit isn't your only concern, i.e. you care about equity? For example, how do you decide whether it's better for you to invest in a vaccine against measles, mumps, and rubella or malaria? Or how do you decide whether to invest in a vaccine that has one set of physical characteristics versus another set of physical characteristics? So for example, is it better to invest in a 1-dose injectable that requires refrigeration versus a 3-dose patch delivered vaccine that doesn't require refrigeration? Now, these are actual decisions that are big organizations in global health are making literally as we speak. So it's not an abstract problem. It's a big problem right now. So why this problem? So the short answer is there are limited resources, and from profitable vaccines in particular. I'm preaching to the choir when I say vaccines save lives, and I'm also preaching to the choir when I say that it takes a huge amount of money to move a vaccine from development to deployment. When there's money to be made, it's really easy to convince the private sector to enter into that market, but there's not always money to be made, and and without making some change to the system, and that's particularly true when you're talking about a vaccine that's targeted at a relatively poor population or a disease that doesn't have very many people, like some of the neglected diseases. So if you want to engage the private sector, which you basically have to at one point during that pathway, that value chain for vaccines, you're going to have to figure out a way to either decrease the effective costs to the private sector, or decrease their risks, and ideally both. And so who can do this realistically? And the answer is governments and big global donors. So you can see on the left-hand side, there's a little cartoon of the vaccine value chain, and I've pointed out some really big players in the area and where they have influence. And by influence, I mean financial levers. So one of our clients, the Bill and Melinda Gates Foundation, tends to make a lot of investments in the vaccine R&D space and the manufacturing space. And their ask of us was to develop an approach for prioritizing vaccine investments with an eye towards equity that was applicable to them, but also applicable to the private sector, who they knew they would eventually have to engage. And I'm not going to go into the details of what we did, but suffice it to say, the problem is complicated. And one of the reasons the problem is complicated is because it touches a huge number of disciplines. So this is just a snapshot of the disciplines that we had to play in. As someone who was trained as an interdisciplinary scientist, this was a dream project, but it wasn't without its challenges, because no one in our group had all the expertise across all those areas that were needed. Now, I mentioned earlier that we didn't engage any faculty at Michigan. And a big part of that was that a lot of the questions that we had were really one-off questions, where if you were a deep expert in the area, you would have been able to say, oh, just go to this paper. They showed you how to do it. And frankly, I didn't know who to ask. And so I never did. And so we did our own research, and we probably took longer than we needed to take. So from my end, even having this list of people who's operating in this space and who'd be willing to field a random question would be fantastic. But it's also helpful when we're putting together grant proposals, because we work a lot in this space. This is frankly our biggest space right now. So for me, this is a great arrival to have this group on campus. And so finally, talking a little bit about, so from our end at WDI, I think our little perch at WDI, we see so much opportunity for multidisciplinary work along that value chain that's focused on equity. I mean, I know all too well how hard it is to work across departments, let alone schools. So I'm not saying this is going to be easy, because we have different vocabularies, different conventions, different approaches to solving problems. And those can be really big strengths, but they can also be really big barriers. And so figuring out how we can clear those barriers seems like it's a really big, important part. But I can't imagine an institution that would be better at doing it than Michigan. Just thinking across this country, like there's literally no one that has as many top 10 institutions at a school or colleges at a school than we do. So I'm really excited. This is wonderful. And thank you for the opportunity to share my perspective. And I hope I get to work with some of you soon. And that is all.
Thank you, Dr. Leroueil, really making a pitch for the whole purpose of the new Center for Global Health Equity at the University of Michigan, and an invitation for us to collaborate across boundaries, as you suggested. So our fifth and final speaker is Dr. Shobita Parsa Sarathi. Dr. Parsa Sarathi is Professor of Public Policy and Women and Gender Studies and Director of the Science, Technology, and Public Policy Program at the University of Michigan. Welcome.
Wonderful. Thank you so much. I've really enjoyed listening to all of the talks, and hopefully I can bring a somewhat different but allied perspective. So I'm a social scientist. I might be the lone social scientist or card-carrying, PhD-carrying social scientist on this panel. My research focuses on equity and innovation policy and the related politics. Yes, I said politics. I'll get back to that. I've written extensively about patents and their public health, social, equity, ethical, and innovation impacts. And more recently, I've been analyzing the rise of inclusive innovation policies and programs to address international development challenges with a focus in India. And I'm sorry to say that despite the language of inclusivity, some of the work that I've done so far suggests that they often still have the kind of problem that Dr. Mathew was talking about, which is that the solution constructs the problem orientation. I've also examined what more equitable health innovation policies might look like. In my work, I ask questions like, how can we design innovation itself? And by that, I mean even down to the technical details. Innovation incentives, as well as innovation policies, to be more equitable and just. How can we decolonize innovation? Now, some of you may be familiar with that kind of terminology in the context of emerging movements around decolonizing global health. But basically what it means is, how can we minimize long-standing power imbalances, many of which took root in the colonial era? And then finally, why are we so resistant to bringing innovation and innovation systems into the conversation about equity and health equity in particular? So armed with those questions, it won't surprise you that I'm deeply concerned in the short term about the lack of COVID-19 vaccine access in low and middle income countries. But I'm also deeply concerned about the long term, and particularly how we can ensure rapid and broad global access to medicines for the next epidemics. For too long, we've framed access in terms of humanitarianism and donation, which is repeatedly proven inadequate. Even just right now, the kind of public-private partnership, quasi-humanitarian framing of COVAX initiative has been problematic along multiple dimensions. And the humanitarian framing does not make real progress towards increased capacity, self-sufficiency, or real empowerment, and perpetuates the power imbalances I mentioned before. So when I'm thinking about addressing these issues for the current pandemic, I've supported a three-pronged approach and described my reason in a policy brief that I wrote early this year. When we're talking about COVID, there needs to be global sharing of intellectual property. The Indian and South African governments have proposed a patent waiver at the World Trade Organization called the TRIPS waiver for the WTO's trade-related aspects of intellectual property agreement. Second, there needs to be some incentive for pharmaceutical companies to share their know-how, the tacit knowledge that's not included in the language of patents. And then finally, there needs to be support for increasing manufacturing in low and middle income countries, both in terms of supplies, but also in terms of allied technologies like syringes. mRNA vaccines in particular are an interesting advancement because they are likely to be easier to manufacture in low and middle income countries. They can be developed in smaller facilities with far lower capital costs. Former CDC Director, Dr. Tom Frieden has suggested a competitive process that would select producers in 4 regions, and these producers would agree to develop products that are reasonably priced and adhere to quality standards. Multiple low and middle income countries that have either produced pre-qualified WHO vaccines or have displayed leadership in health technology would be potentially in a position to jump in this way. But all of this is just the first step to manage the current pandemic. The really wicked problem, of course, is to develop long-term solutions. For that, we need to develop and maintain technical capacity, both in terms of the workforce, but also in terms of laboratories and manufacturing facilities. This capacity needs to be nimble, building on what these countries already have, and responding to indigenous problems on a day-to-day basis. But these facilities also need to be ready and willing to shift in the context of an epidemic. Over the long term, these facilities might innovate their own essential medicines, developing technologies that are both needed and work in and for the local context. But we also need governance mechanisms to jumpstart this activity and also ensure widespread sharing of intellectual property, know-how, and materials early in the next pandemic. To do this, we need to figure out the circumstances that would trigger this kind of sharing, and then develop sharing protocols and responsibilities well in advance of when a pandemic were to begin and to work across pandemics. This would hopefully avoid one of the problems that we've seen in this one, in which we have debated and dithered, losing precious time in which we could have been scaling up manufacturing and vaccinating people. So I want to spend most of my remaining time on the politics of all of this. We might be tempted as researchers to think that politics is just a problem to be overcome, that our primary job as researchers is to find the best solution. However, in my research and in my book, Patent Politics, I've demonstrated that how we understand the viability of proposals related to vaccine equity are profoundly shaped by the social and political environment in which we're operating. And by that, I don't just mean policymakers, I mean researchers too, in ways that we don't often realize, and it constrains us, I think, in dangerous ways. So I mentioned the TRIPS waiver earlier, and many often respond to that proposal by saying either that it won't work or that its proponents don't understand the system. That response is politics at work. Historically, in Western countries and in the United States in particular, we have believed strongly in unfettered intellectual property rights. From the founding of this country, patents have been seen as crucial to economic and social benefit, and the inventor's interest has been seen as the same as the public interest. And despite mounting evidence to the contrary, the ideology has remained supreme that patents are crucial to innovation. In part as a result, we've constructed intellectual property as disconnected from issues of public health. By providing incentives for making new technologies available, governments and patent holders have successfully argued intellectual property does not harm public health. Any problems with vaccine equity, we're told, are issues of healthcare and not of innovation and intellectual property, again, despite evidence to the contrary. We're also taught that patent systems are simply administrative domains that certify inventions rather than regulatory systems that make reasoned decisions about the kinds of monopolies that are in the public interest. And finally, as I suggested, those who disagree with any of these elements that I've just described are constructed as ignorant or misinformed. These are what I call expertise barriers, formal and informal rules that are used to maintain the dominant way of knowing the patent system and delegitimizing challengers such as public health officials or civil society groups. It's crucial to understand that these ideas about patents, that they're overwhelmingly good and crucial for innovation, that they're disconnected from or beneficial to public health, that patent systems don't do regulatory work, that critics are ignorant, are shaped by the political environment. And yet we see them as natural, and thus they constrain our solutions without us even realizing it. The problem here isn't that public health experts and civil society groups who support the TRIPS waiver, for example, don't know, is that their knowledge has not been historically taken seriously, both in terms of research and in terms of the political environment of the innovation system. And the problem for vaccine equity is that these political dimensions tend to lead us away from the very solutions that might be the most effective. So part of my job as a social scientist who critically examines the politics behind access to essential medicines is to identify these frames and blind spots and figure out how to overcome them to achieve equity. So where does collaboration fit into all of this? So obviously, of course, I'm going to say that to develop short and long-term solutions for vaccine equity, in addition to scientific and medical researchers, we need experts in law and international relations, but also social scientists who understand technologies in their social and political context. We need practitioners from policy and civil society. But perhaps most crucially of all, we need to take the knowledge and perspectives of people from low and middle income countries seriously, both those who have expert credentials, but also those who may not have as much formal education, but often have crucial knowledge related to public health and public policy. To go back to what Dr. Mathew was talking about, the kinds of questions around why families choose to vaccinate in particular order or not at all, those are the kinds of questions that may have answers that are rational and logical. And so here I want to also link questions around what may appear to be or are often framed as vaccine hesitancy to issues also around distribution and innovation. So all of this is not just about diversity for diversity's sake. Rather, it's about ensuring that the technologies and innovation systems that we develop are appropriate for the context and are likely to be accepted and distributed widely to achieve societal benefit. And it's about getting us out of an endless cycle of charity in which marginalized communities are never really properly served. So I'll stop there and I look forward to the discussion.
Thank you, Dr. Parthasarathy, and to all of our speakers. I might invite each of our speakers now to turn your audio on and keep your video on. And before we turn to questions from our audience, I would invite our speakers to raise any questions or responses you have to what you've heard from each other. Several of you have commented on some of the other presentations in your own remarks, but any other questions or thoughts that you'd like to raise before we go to the questions from the audience?
I really appreciate the perspective that Pascal, Dr. Leroueil brought to the conversation. I don't think we often get to see the industrial business side, which is incredibly important for all the decisions that are made along the decision pathway of any vaccine or any disease that's going to be potentially prevented by vaccines. So I want to say thank you.
Thanks, Diane.
John, I might just mention that the Gavi, which one time was known as the Global Alliance for Vaccine Immunization, and they just go by Gavi now, but is a public-private partnership that was expressly developed to assist low and middle income countries with the regulatory oversight for vaccine production. And I think a lot of people don't know that China is now the largest vaccine producer in the world. And Gavi's been very active in China, in India, and Brazil, all of which are producing lots of vaccines. I saw a question in the chat, not to jump ahead, but about diseases that aren't of relevance to Western nations and the implications for vaccine production. And that's one of the express reasons for Gavi's development, in fact, was to address that very issue, that these diseases like neglected tropical diseases that mostly occur in poor nations weren't of particular interest to Western pharma, and that Gavi was developed to address that issue and assist other countries with vaccine development, including the regulatory mechanism and oversight for that.
Yeah, and just to follow on what Dr. Boulton said, so Gavi is doing something right now as we speak called the Vaccine Innovation Prioritization Strategy, which is basically where are we headed in the future? Where do we want to signal that this is where we're going to try to make investments in? And it's to signal to both manufacturers as well as people in R&D. So they're part of that entire chain process.
Great, thank you. So I want to turn to one of the questions posed from our audience, and it relates to one of the guiding principles of the Center for Global Health Equity here at the University of Michigan, which is that the work we do should have a foundation of bidirectional learning through respectful partnerships with colleagues and people in low and middle income countries. And the question that was arisen about that principle is, are there good examples where the voices and perspectives of people in low and middle income countries have been impactful in the conversations that we're having about vaccine equity, where often the voices of folks in higher income countries that are more privileged become more visible in these conversations? And Shobita, you referenced this towards the end of your remarks, like what could be learned from a social science perspective by actually understanding and working with people in the communities affected by some of these vaccine preventable illnesses. I wonder if you want to take that on first, and then I might turn to Dr. Mathew as well to comment.
Sure, I'd be happy to talk about this. This is something dear to my heart and something I think about a lot. And I think that the bottom line is that unfortunately now we do not have adequate attention to the voices of people from low and middle income countries. But I also want to make a distinction, because I think that sometimes, and I think increasingly, and I think that this is a wonderful change, is that we're now starting to incorporate kind of experts from low and middle income countries. But there's also, while experts from low and middle income countries often bring a crucial perspective, they are also not necessarily representative of the most of low income and marginalized communities in those places, right? They're often as part of a global community of scholars, of researchers, et cetera. And so you have, for example, in the recent COVAX program, one of the critiques of that program, and that could be said of a number of other similar international initiatives, they haven't actually engaged either the kind of what you might consider the experts from those countries or the people who are actually the people we want to increase their levels of vaccination. But I think that I will just say finally that the reason that I'm trying to make that distinction between experts in low and middle income countries and actually marginalized communities is that the logics, the rationalities, the lived experiences of people in those communities we tend to think of as perhaps irrational or problematic or uninformed, but they are real lived experiences. And if we actually want technologies or policies to be effective, we have to take that seriously and respect it. And the problem, of course, is that this kind of consultation or democratic deliberation can often take a long time. And there's also the problem that these communities are often mistrustful of whether it's scientific or government elites. But that's in part why part of what I'm suggesting here is that we have to develop long-term solutions, long-term relationships where we're actually engaging with communities and talking about their priorities as well. What do they care about in terms of inoculation? What are the kinds of, are vaccines at the top of the list? Are other kinds of problems at the top of the list? Those are the kinds of conversations that we start now. We can build relationships that we can leverage in the long term.
Thank you for a thoughtful answer. Dr. Mathew, your perspective?
Yeah, thank you. I agree that, in the recent years and decades, there has been an increasing movement wherein voices from the low and middle income countries are heard at the table. But the catch is that these are compliant voices. You know, the ones who are invited to these meetings and discussions are those who speak the very things that the rest of the crowd wants to hear. If you were one who had a slightly different idea or a perspective which didn't match with the trend, then you wouldn't be invited to these meetings at all. That is one point. The second is the tradition in which it was a hand-me-down kind of a thing, that this is what we've decided, you take this and implement it in your country and we will give you the honors and the accolades and stuff like that, has now changed to a little bit of a partnership kind of an approach. But the partnership is not an equal partnership, in the sense that it's still more or less that this is what we've decided, you need to implement it, but come along, sit at the table with us, we will listen to you, but ultimately you're going to do what we've asked you to do. In certain countries, this works. In countries where there is either a lack of empowerment amongst the academicians or the policymakers or the people themselves, this might be a beneficial approach at times. For example, if I think of Bangladesh, the whole healthcare system there has got transformed by this donor recipient kind of relationship. Whether it is vaccination, other kinds of healthcare, they benefited immensely from that. But then that country may not have the number of people or critical mass required to do independent thinking. India, unfortunately, is not in the same boat because we have enough of academia, we have enough intelligentsia here who should be able to take the decisions on their own, but don't have the wherewithal to do it or don't have the opportunities to do it. In many parts of Africa, the same pattern as we are saying in Bangladesh also works. Malawi, for example, these are what I call research labs for big prestigious agencies in the developed world. And they go and do these research studies over there, transform the healthcare system. There is a lot of benefit from that, but then they don't leave the system to be able to fend for itself and stand on its own for the next communicable disease or the next issue that needs to be tackled. Yeah. So I think that is my perspective on that. Thank you.
Thank you. I'd like to invite Dr. Scott Stonington, who is a faculty colleague here at the University of Michigan, a primary care physician and anthropologist, who put an insightful comment in the Q&A box earlier, and which is in the answer tab for those of you watching. Scott, what is your view is from an anthropologic perspective on this question of engaging people at the community level from low and middle income countries in not just providing information, but the actual decision making that we're discussing around vaccine equity?
Hi, everybody. Thanks for calling on me. Give me a thumbs up if you can hear me, because I think I have audio but no video access to the webinar. So I think the main thing that I would say about this as a very, very important thing that I think people in many different fields are thinking about, this idea of how do we go about decolonizing our processes and our structures and our relationships. And rather than speak from it from a generic anthropologist perspective, I would love to turn that question in a way back on the center, because the center is starting to emerge. We're starting to build the structures that we envision that will bring our many agendas into reality. And some of the things that have started to emerge out of that, like will we become a data hub where we are gathering, let's say if it's one of our foci to focus on vaccine equity, where we're going to gather information from all over the world about that particular topic. We are starting already to make very concrete decisions about how we relate to that information and to the sources of that information. So do we see ourselves as a set of experts who are gathering data from all over the world and then we get to analyze it? Or are we a relationship hub where we start to collaborate in very equal ways with centers elsewhere in the world? Or, for example, are we a place where we are trying to look for ways that novel information and perspectives can be generated kind of de novo and fresh in places around the world that we are able to fan the flames and incubate and be sort of support behind the scenes for other sorts of voices? So I just want to throw out that it's not an abstract question, because we're starting to build this stuff, and I haven't been there for some of those conversations. So I'd love to hear, as this is one of the places where our community is gathering to start to make those choices, whether where we are in the development of those conversations. I would love to hear. And John, if it's too much for me to kick back such a big question to you that takes us away from the specific stuff about vaccine equity, then feel free to set it aside.
No, thank you, Scott. That's really food for thought for all of us engaged in the center. And really the purpose of these webinars are to engage our broader community in taking on the questions like you just raised. And even with the language, we've moved away from the concept of a data hub, which implies that we're at the center of the universe here at the University of Michigan, and really thinking more about a data collaborative and a data portal, where it's all about sharing information and knowledge and hopefully wisdom and productive action coming out of that information and knowledge. So I might invite our panelists to reflect on the question Scott posed, and particularly in the context of vaccine equity, which we're envisioning as a major new initiative and area of focus for the Center for Global Health Equity. How can we approach that thoughtfully and effectively in the ways that Scott challenged us to do?
And if you don't mind, I might add one quick thing that brings in a little bit of why you requested me to speak as an anthropologist a little bit, which is some of what we've named as the thing that's missing from our understandings of vaccine equity in particular places is voices and stories and how people's ethical, local moral worlds are put together. So I'd love to hear, in addition to that, as of us as a data, what would you say we are?
Collaborative. Data
collaborative. That's the data that's harder to incorporate, is all of that quantitative and detailed stuff about people's real worlds all over the world. So I'd love to hear any thoughts about how we might do that.
So John, so I'll respond. I mean, so Scott, I don't think I have the answer to your question, because I think we're still sorting that out at the center, particularly in the context of this global vaccination equity. But there's been a model that has been used at the School of Public Health, community-based participatory research, in which the community in which you work is an equal partner in identifying the priorities for the work that you do as an academician. And it's a model that a lot of us, we're never trained in, and it's a more difficult model, I think, to work in. But I do think that there has been a general movement towards trying to ground the research that is being done, or the grant awards that are being made in the needs of the community as identified the community. I was just on a call earlier this week with someone from the Gates Foundation, and they were talking about the transformation of their model, in which everything used to come out of Seattle, but now there's these country level offices dispersed around the world that have primacy in terms of that are staffed by individuals from that country. They have primacy in making determinations about what the research priorities will be. And it seems to me that model, moving towards a model like that, a community-based participatory model, is something that we need to give serious consideration to. While I also recognize it's a tougher model, to work with, than opposed to just getting the data, and analyzing, and maybe having a partner or two from that country on the paper, which, for a lot of folks, that's always met our definition for partnership, but it's definitely extending beyond that now.
Thanks, Matt. Other thoughts, Shobita?
Yeah, I'd love to jump on this, and I really appreciate the provocation, Scott. I think that CBPR is a really interesting model and start. One of the things that I think, you see can be problematic with CBPR and other kinds of, so there are other sorts of democratic deliberative mechanisms like consensus conferences, citizen juries, that have been used extensively in low and middle income countries, is that I want to kind of put a orientation on the table potentially for the center, but the Vaccine Equity Initiative in particular, which is that the role of communities is not just in kind of getting feedback on proposals, but even how we develop what the research questions are. that fundamentally changes our position in terms of our power. It's an uncomfortable position, not just because it takes longer time, but because we're all used to being experts and knowing. And so that's the first thing I would say. And the second thing I would say is that I really appreciate what Scott said about kind of data versus real world. I think he was talking about, but just to maybe put that into slightly different terms. We're talking about lots of different kinds of data, quantitative data, qualitative data, but also data that may not look to some of us like data, and they may not all serve the same function. And I think that, again, needs some intention at the outset. Some of the kinds of things that we're talking about, for example, framing these questions to bring marginalized communities into the center of developing the questions themselves, are more frames, right? They're about how we should think about a problem, how we should devise our problems, what we should not, as I was saying before, what we should or should not leave on the put on the table. That's different, I think, than the data that we might generate from other parts of the initiative. That might, that there may be staging, and so not all data is the same, especially when we're thinking about rebalancing power in this context.
Other thoughts from our panel? One question I wanted to bring up as the moderator is, it's been in the news this week that the World Health Organization has endorsed the malaria vaccine for use in children in areas of the world affected by malaria. That will be a very important development if that can be implemented. I wonder, with that kind of news that we've been hearing this week, how does vaccine equity and some of the principles that we've been discussing today in terms of evidence and partnerships and how decisions are made and resources are allocated, and any thoughts about how that vaccine may be affected by the discussion we've had?
Yeah, can I take that one up first?
Please.
So this is the usual model. A vaccine is available. It's manufactured by an international company. The vaccine needs to find a market. Now the WHO has endorsed it, which means there is pressure on developing countries across the world to somehow get it in. But the point which has not come out in the discussion is, what's it going to cost in terms of per dose cost? What is it going to cost in terms of vaccinating? And what's it going to cost in terms of vaccinating the ones who really need it, as opposed to the ones who can get it, but who might not really need it? Now, while all this is happening, and the low and middle income countries are grappling with these three realities, the vaccine is going to be flooded into the markets, and haphazard sales are going to take place. A lot of doses are going to be sold to people who don't really need that. A lot of people are not going to get it who actually need it. So that disparity and inequity is going to be there. And by the time these countries figure out how to sort this out, either local manufacturers, if it is a technology which can be replicated, will come up with a vaccine which will push the prices down, as happened for hepatitis B vaccine, in which case the focus will completely shift from malaria to something else. On the other hand, if the technology cannot be replicated and there is no local vaccine which is coming up, then this will continue for about 5 or 6 years until a new vaccine comes up and the whole relationship. We've seen this cycle for the past few decades for virtually any vaccine that we can think about. So I'm expecting nothing very different with this one as well. But that's just my perspective. I might be completely wrong this time, which would be great. Thank you.
Thank you. And you're drawing on the history of other vaccines to help inform what could happen with this one. Pascal?
I was, to me, I'll echo what Dr. Mathew said, that this was a solution looking for a problem. So for example, if you've paid attention to the news, you may have noticed that Gavi was very quick to say, we're going to do our own due diligence to figure out whether we're going to be purchasing these vaccines. And Global Fund, which is the organization to fight HIV, TB, and malaria, clearly has an interest in malaria. They haven't done their own cost-effective analysis as of yesterday. So there's a situation where you have two big global players who clearly should have been doing stuff while this was happening, who knew this announcement was coming, yet did nothing to think about, is this the right move to increase equity? Is this the right move to reach people who we've not been able to cover using nets, for example? For me, it's it's an interesting decision on the part of those donors to not have been ahead of the curve on this.
Mm-hmm.
I'll also add briefly, you know, I mean, I echo Dr. Mathew's concerns, and two things that strike me about it was, of course, the relatively low efficacy rate, but also the fact that it's 4 shots. And again, those are design questions. That's, you know, whose interests are being served, and of course it's very likely that the narrative from the market-oriented narrative is that there's something wrong with the people because they're not taking this vaccine, right? And that makes it sound like the problem is one of vaccine hesitancy instead of one of distribution or information or engagement with publics.
Yeah, you know, John, that's a really good point. Because the efficacy, I mean, there was a lot of debate because the efficacy is so low, which, you know, vaccines against parasitic diseases are extraordinarily challenging because there's such diverse organisms. And, you know, there was a number of different malarial vaccine candidates, but all were characterized by, you know, relative to other vaccines, actually exceedingly low, you know, vaccine efficacy. And that really is an issue that deserved more, I think, discussion on the global stage with the implications of that, and also who it's being provided to. I mean, I think there were lots of unresolved issues at the time that this vaccine was put out on the global market.
Diane, did you have a comment?
Well, I wanted to say that as the HPV vaccine was being developed, I worked really closely with the 2 different commercial partners, and they would never release to another partner or to the public or to anyone what their data showed or what it was until the day they released it. So it's not at all surprising to me, Pascal, that the other people were caught flat-footed, because that is part and parcel how they maintain their proprietary status, right? And so that's not a comment for either here nor there. It's a comment that has to do with business in the world, and how do we create equity when the prime purpose of business is to make a profit for a particular set of people, even if they do give a lot away, and even if they do give things at discount. Kind of the second follow-on to that was that I'm currently working with a journal named eLife, and that journal is highly motivated to bring transparency and data reporting, and to bring in scientists from all around the globe, all genders, all nations, all ethnicities, in order to be able to show how science at the level of the community can produce end results for that community. And the difficulty that we're finding is that while communities may know or identify something that is of trouble to them, they don't have the resources or the background or the solutions to be able to make changes. And so I think I'm really delighted to hear that our Center for Global Health Equity is really reaching out in how do we lend that equity, and what are the appropriate arms? Businesses are a part, but how do we get out of that for-profit, that shareholders' responsibility, which is a global business aspect. That is what makes the economy work. But how do we work with that to allow the solutions to percolate up from the areas of need? So that's all I need to say.
Great. Well, we're at the end of our time for today's session. I want to thank all of our speakers and you, the members of our audience, for your engagement in the crucial topic of today's webinar. I'd now like to invite Dr. Joseph Kolars, Director of the Center for Global Health Equity, to close our session by highlighting some upcoming opportunities to collaborate on advancing global vaccine equity.
Hi, John and panelists. Thank you for just an outstanding session. Very energizing, and I think we're just scratching the surface. I particularly resonate around that last comment. I think the way the community has gotten disconnected from science in our own country here can really showcase the problems that could come, but our opportunities to engage differently and better. Know that this is going to be a major priority for our center. One of our a handful of signature programs. We're putting a lot of resources into bringing people together for solution making. How can academia, by connecting across some of the usual boundaries, be relevant? And we want to come up with some of the information that is going to direct us forward, some of the evidence that hopefully that can be leveraged up. So we're going to be reaching out to people to participate in our global vaccine equity research jam, November 2nd. And we're working our way up to a big ideas lab that is going to be held the end of February. So we're really looking to build a community of practice around vaccine equity. And hopefully what you've heard from this discussion, we don't need all the voices and the perspectives from the different disciplines. Just about every discipline here at the University of Michigan is relevant. But more importantly, how are we authentic in terms of sharing the trail with our colleagues in low resource settings and actually in the community? We need to do better in that regard. So I'm really hopeful and inspired by the group and by the movement that's forming. So thanks everyone for being part of just a terrific seminar today.